All right. Good afternoon, everyone. This is Nikki Anderson, the Stroke System Nurse Specialist. Thank you for joining us today for our very first webinar of 2021. I hope that everyone online with us here today is healthy, happy, and ready to navigate through this new year. We have a few items on the agenda. First up is a program update from Al Tsai, the Stroke System Director. We will also be announcing the QI Award winners. And lastly, Michelle Gray-Ansari, the Stroke System Designation Coordinator, is going to cover some frequently asked questions about this round of designation and site visits. Many of you may have noticed that this webinar was scheduled for 45 minutes rather than our typical 30-minute time slot. We have not hosted a webinar since October and have quite a bit we want to share with you. As usual, your lines have been muted upon entry. We still want you to ask questions by typing them in the chat throughout the presentation. We will be keeping track of the questions and plan to address them at the end as time allows, or we will address questions in our follow-up email. Before passing the virtual mic to Al, there are a few upcoming educational opportunities we wanted to share with you today. First up is an AHA webinar in February on posterior circulation strokes. The flyer for the webinar will be sent in our follow-up email. We do plan for this webinar to be enduring, which means it will be available for future viewing, so don't worry if you miss it the first time. Next up is the CentraCare Neuroscience Certification Prep course on February 3rd and 4th. Then is the International Stroke Conference, which has moved to a virtual platform and is scheduled for March 17th through the 19th. It's a stellar deal this year and will only cost $50 for AHA members. Stay tuned for another flyer from the AHA for the April, Minnesota webinar on ICH management. And then lastly, Donna Lindsay's new stroke course is available on the MDH Learning Center. All of these offerings come with contact hours and/or CME for providers' stroke educational needs. And also, we just want to mention to please continue to notify our team here at MDH of any contact changes within your programs. All right, I'm going to turn things over to Al.
Thanks, Nikki. Can you hear me? Just say yes.
Yes.
Okay, so while many of you over the last several years have seen the data that I'm going to be presenting, this will be a little new to some of you. So I'm just going to give a very, very brief overview of stroke in Minnesota. To start, the stroke death rate declined a lot throughout the 2000s in Minnesota and in the United States, but it has been flat for over the last 8 or 9 years. Minnesota has been consistently well below the national average. Right now, Minnesota has the 17th lowest stroke death rate in the country. Our most recent data on deaths come from 2018, when stroke was the 6th leading cause of death in Minnesota. Unfortunately, when we are able to update this with our 2020 data, we know that COVID-19 will appear on this list as well and will push stroke down one ranking. As is the case in the rest of the country, the stroke death rates are higher in certain populations. Blacks and Asians have the highest rates in Minnesota, with deaths in American Indians going up as well. And these are, of course, very concerning to us. You can see on this slide here, this next slide, with regard to stroke hospitalizations, the number of hospitalizations for stroke in Minnesota, it has not really changed that much over the last several years. We think that there are several reasons that the overall incidence of stroke in Minnesota hasn't changed that much. Some factors pushing towards more strokes, while other factors pushing towards fewer, with the net effect of no significant change overall in the last 15 years. So with all this in mind, we have made great strides towards ensuring that all Minnesotans have access to high-quality acute stroke treatment. We've been implementing a statewide stroke system of care since 2014, when we started designating stroke hospitals. And currently, we have 12 comprehensive stroke centers, 12 primary stroke centers, and 92 acute stroke-ready hospitals. This has been one of our greatest success stories, seeing access to a designated facility rise from 60% in 2012 to 89% of the state's population in 2020 living within half an hour drive of a designated stroke center. And you can see the progression in this next slide that we'll show here. The map on the left, it shows 2012, and 2014 is when we implemented our stroke system of care. And the map on the right here is from our most recent data in 2020, where you can see the darker shaded areas are the drive times 30 minutes around a designated stroke center. The lighted shaded areas are 60-minute drive times. So we've covered essentially about 90% of the state. In terms of outcomes, we have seen an increase in quality of care as well as reach in our stroke system, where over 75% of patients receive a CT scan within 25 minutes. In this graph, we can see that the median time to CT has declined from nearly 70 minutes down to about 27 minutes. Of patients who receive IV treatment, IV alteplase, nearly 80% receive therapy within 1 hour, the golden hour. And the median time to treatment, door to needle time, is now under 55 minutes statewide. In terms of treatment overall, treatment has gone up from about 4% when we started tracking this in 2008 to about 13% of all ischemic strokes. Notably, 90% of eligible patients get treated in Minnesota. And of those who don't get TPA, the reason for 75% not getting treated is because they arrive to the hospital outside of the treatment window. So this is still our biggest challenge, in my opinion, and our biggest opportunity. That is to get people to recognize a stroke happening sooner and calling for an ambulance immediately when symptoms begin. I'll close by adding that the number of mechanical thrombectomies has been steadily rising since 2013. Data to date in 2020 show that we're still on track for a pretty big increase in thrombectomies, even though COVID-19 threw a lot of things off. 2020 was an unusual year for stroke in Minnesota, as it was across the country due to the pandemic. Our preliminary analysis is showing that emergency visits for stroke were 30% lower in 2020 than usual, and stroke patient admissions were down about 19%. In addition, the average time from symptom onset to arrival was higher, resulting in more patients coming in with severe strokes. However, because of delays in seeking care, fewer patients were able to be treated with IV alteplase than in years past. So there's a lot that happened in 2020, and we're still doing some analysis on that. I will close with that. Thanks again for your participation and for your work to provide high-quality stroke care in our state. And with that, I'll turn it back over to you, Nikki. Thanks.
Thanks, Al. All right. So next up today is our QI Awards program. Now, right as the pandemic was starting to affect us here in Minnesota, we announced this awards program. And that was during the 2020 March webinar. And there we also shared some quality improvement strategies, examples, and also included the announcement of the awards program. The reason we developed the awards program is because we know that QI is embedded in every one of your programs, regardless of the designation level. There are amazing examples system-wide of collaboration, creativity, and resiliency. With that said, it quickly became our goal to recognize successful quality improvement initiatives throughout the Minnesota stroke system. And like all things with COVID-19, our original plan changed for announcement of the awards. The Minnesota Stroke Conference was held virtually this year, and to be honest, we weren't ready to make the announcements then, but we are today. Each award winner has received an individualized plaque and will be showcased on our new Quality Improvement Awards section of the Minnesota Stroke website, which should be live next week. We developed 3 award categories, and the first is the Continuous Impact Award. This is an award for starting an initiative that creates a meaningful and long-term improvement in quality of stroke care. Next is the Operational Excellence Award, and this is an award for an initiative that focuses on collaboration between different programs to improve quality of stroke care. And lastly is the Outstanding Achievement Award. This award is for the initiative that led to evidence-based positive change in quality of stroke care. Now, we did recognize 2 hospitals per category. The first award winner is Lakeview Hospital, which is an MDH acute stroke ready hospital in Stillwater, Minnesota. Karen McLean is the stroke coordinator there. Lakeview Hospital identified an opportunity to improve their door-to metrics for stroke patients. They developed multiple resources, trained staff, and tracked progress and made adjustments as needed. They achieved improvements in all of their door-to metrics. Congratulations to Lakeview Hospital. Here's a little virtual round of applause. All right. Next up, for the Continuous Impact Award, we have the Mayo Health System Southeast Region, which the coordinator there is Brooke Warm. During their acute stroke ready hospital application process, they identified that they needed to improve their stroke code activation system. They worked together and developed a formal stroke code process that was designed for region-wide use. As a result, they had a total of 135 code activations in the first 7 months of 2020. Congratulations to Mayo. All right. The next award is Operational Excellence. And the first award winner for this category is Ridgeview LeSueur, which is, again, an MDH acute stroke ready hospital in LeSueur, Minnesota. The stroke coordinator is Kari Wallace. They worked on decreasing their door-to-CT times. Multiple stakeholders were involved in development and implementation of the action plan. And as a result, their door-to-CT times decreased to under 25 minutes. Well done and congratulations. Next up in the Operational Excellence category is Mayo Clinic in Rochester. They are a Joint Commission Comprehensive Stroke Center. The program coordinator is Jen Wells Pittman. They identified an opportunity to decrease the amount of time patients with stroke symptoms spent waiting for endovascular clot retrieval upon arrival to the hospital. They pulled together a large multidisciplinary team to work through the process. And as a result, all patients that have gone through their direct to endovascular pathway have been within goal time. Congratulations to the Mayo team. Our final category is Outstanding Achievement. The first award winner for this category is Wellia Health, an acute stroke ready hospital in Mora, Minnesota. At the time of the application, Jill Sawyer was the program coordinator. She has since retired, but Amanda is also a vital part of the stroke team and continues to work at Wellia. Strong work, stroke team at Wellia, and congratulations. Now, again, I just want to mention that their QI project consisted of decreasing door-to-needle times, and as a result of this initiative, 100% of their treated cases were within goal time. And the final award winner is Sanford Medical Center, Wheaton in Wheaton, Minnesota. The coordinator there is Shelley Bernig. Their QI project was related to stroke code activations, proper utilization of order sets, and improved documentation, and lastly had an emphasis on improved door-in, door-out times. There was an increase in stroke team activations. 100% compliance with NIH stroke scale documentation, and 71 patients were transferred within goal time. Another excellent example of QI work. Now, I do want to mention there were a few other honorable mentions that applied for our awards program. Community Memorial Hospital in Cloquet, Essentia Health, St. Joseph's Medical Center in Brainerd, Lakewood Health System in Staples, and North Memorial Hospital in Robbinsdale. Thank you all for your participation. Pictured here is a screenshot of the QI Awards section of the Minnesota Stroke website. This will be live, as I mentioned, hopefully next week. Please visit the website for full stories. And again, congratulations to everybody. The good news is we are doing this again this year here in 2021. Watch out for communication in the coming months. The anticipated deadline for applications will be at the end of August. And with that, I'm going to transition things over to Michelle.
Thank you, Nikki. Congrats to all of you that submitted your fantastic performance improvement initiatives, your quality improvement initiatives. We're really proud of you. It's fun to see the award winners. I'm going to start my video here. Good to see everyone. Okay, so let's transition here, and what we wanted to do today was hope to answer some of your frequently asked questions about this new cycle of designation, which started in 2020, the same year as we had an epic pandemic hit our state and nation and world. We finally called this cycle of designation 3.0. And really, what we want to do, though, is kick off and truly thank you. Thank you all for your stroke programs, for your continued dedication to acute stroke care and designation and redesignation during this challenging time. We understand that there are a lot of questions about designation considering all of this and the pandemic. So we're attempting to answer what we have come in the most frequently. But for any and all remaining questions that are on your mind, please type them into the chat and or follow up with us individually, and we'll make sure we follow up with you. Has our acute stroke ready hospital designation submission in the Minnesota Stroke Portal or designation site visit timeline changed as a result of the pandemic? The very first most popular question. And the first thing I want to clarify is that the MDH stroke program has not changed any of our submission deadlines for acute stroke ready hospital designation. I understand that the trauma program has a different process in place, which has included a delay in designation, submission, and site visit. This has caused some confusion for some of you, but just to reiterate that we have not changed any of our timelines. The designation process is a 3-year cycle for stroke, so your submission of acute stroke ready stroke documents is due in the Minnesota Stroke Portal every 3 years. You will receive 6-month and 3-month check-in reminders and resources from us prior to your deadline. Please review those emails as they have a lot of helpful information. Remember, you can also find designation and site visit resources on the resources page of our website at any time. So I would highly suggest getting a head start, doing a little bit of homework. And we really, truly thank you again for all your hard work during this time. So the next burning question is, when can we expect our site visit to occur after we submit our documents in the stroke portal? The only aspect of designation that has been affected by COVID-19, especially for those that submitted documents this last year in 2020, was the delay of scheduling the corresponding site visit, as well as the incorporation of remote site visits for some sites in order to complete the designation process safely. But from here out, you can expect for your site visit to occur closer to that submission deadline. For example, for those that are due shortly here, we have a couple months. In the Minnesota Stroke Portal, April 1st, 2021, we've already been in contact with you, so thank you so much for staying on top of those communications from us and reach out as you prepare. You can expect your site visit, if you submit this April 1, to occur anytime between May and October. You will receive more communication about your site visit closer to your submission deadline. Third here, it feels like we just had our site visit. Are we really due for redesignation? And the answer is probably yes. During the 2.0 designation cycle, there was a gap from the time of submission of documents in the portal to the actual on-site visit. You might know that this was up to a 12 to 18-month gap for some hospitals, which was quite a bit of time between when you submitted your documents to when we were actually visiting you. Please remember that this site visit completes the designation process this time around. That was a process change for us and for you. Therefore, you will receive all recommendations at the site visit and in the follow-up report, versus a set of recommendations after submission and a second set of recommendations after the site visit. We really hope this makes the process more efficient for your stroke program and for us in the long run, to really focus and hone in on what we are recommending in real time at the site visit. So what are you to expect with your site visit during COVID-19 pandemic? Well, surely COVID-19 has rattled us all, and we've had to adapt in ways we never really imagined. This is a common question and is completely understandable. We are moving and adapting as quick as we can as well, so we appreciate your patience and your dedication. So where are we? So last spring and summer, we paused site visits and quickly developed the remote site visit process. We are continuing with remote visits for some sites, as well as scheduling in-person visits. This started in the fall. We take multiple things into account when scheduling in-person versus remote. For example, local case counts and comfort level and capacity of the hospital staff, reviewers, and us, the MDH team. We will work with you in advance to schedule your visit. As things are constantly changing with the pandemic, we will remain flexible and adapt as we need to. Please always reach out to us if you have any questions or concerns about this. As far as who is required to attend, when we are in person, we kindly ask that you keep your attendees to a minimum and incorporate safe practices and social distancing throughout. Even for in-person visits, we encourage that you set up your own meeting technology where others can participate remotely if they choose, especially for the opening and closing sessions. This may include your hospital administration who want to tune in and hear about all your great work, EMS liaison, and other key stroke team members. For remote visits, we kindly ask that your program set up the technology platform for the site visit meeting. Once a date is determined, and that communication will occur between you and I. So does that mean, does your hospital typically use WebEx? Do you use Microsoft Teams? Do you use Zoom? Considering you are the ones sharing your screens to present, sharing the medical record for case review, and showcasing other documents, it really works best for you to host the technology versus trying to get used to a new technology that is driven by us here at MDH. So you can probably expect that ask by the time we are beginning to schedule your site visit. For both in-person and remote site visits, the stroke coordinator is required to participate in the entire visit, with the stroke medical director requested to participate in as much as possible. But understandably, especially during this time, they're only required to join the opening and closing sessions and also be available for questions along the way. Please also remember, if your hospital has made any adjustments to your stroke policies or protocols due to COVID-19 or other reasons, please be prepared to discuss these changes and the outcomes during your site visit. It's also helpful, although we're taking a real-time look at your documents that were just submitted, if anything has changed from your submission, please send those our way so that we have a fresh look and can look at all of your current programming efforts. Okay, to some administrative logistics here. Why can't I update the primary and secondary contacts in the Minnesota Stroke Portal application section? We get this question a lot, so hopefully this helps. The reason for this is because the primary and secondary contacts are part of your facility information, which is controlled by us here at MDH. So you're entering all of your application information, but some is rooted in the portal based on your facility. So if you need to change those staff members that you see under those sections, please contact any of us, any of the MDH staff, or health.stroke@state.mn.us. It's important to note that when we create a contact within the portal, we need the first and last name, email address, and phone number to have it be complete. Another question we are getting, which is awesome to see that people are really wanting to stay connected with fellow acute stroke ready hospitals. Can you connect me with an ASRH coordinator with a hospital of the same size? So what we suggest is to start by contacting and working with your PSC or CSC partners to see if they have any recommendations for you. There likely may be other hospitals within the same telestroke network, which is the best starting point because you have that common ground on some of your protocol and processes that are in place. So it's the best place for kind of sharing best practices and working through some of the designation together. It is also suggested to contact with other acute stroke ready hospitals within your same health system. We've seen great success when hospitals collaborate and work together within their system. Namely, the QI Awards noted the Southeast region of Mayo, and they did just this. You can, of course, reach out to us here at MDH, yet we will first recommend you trying these two options before troubleshooting any further. So what happens after I submit my designation documents in the Minnesota Stroke Portal? Once you submit your documents into the portal, they're sent to our application review team, our committee, for clinical review. The clinical review team provides us with feedback and recommendations. We, MDH, compiles all of these recommendations for your site reviewer, in addition to reviewing and compiling your previous site visit recommendations. So remember, whatever was listed as a recommendation last site visit time, this would be required to be addressed by the time we get to this site visit in 3.0. Anything that is not verified or validated during the site visit will be included in your final written designation report. Are there any new recommendations since designation 3.0 has started? This is a great question, and yes, as the MDH stroke program and your own has developed and stroke guidelines have changed, so has our corresponding stroke program recommendations. In the next few slides, I'll share a few common, new, immediate actions, recommendations, and that you might see in your final designation site visit report. We also wanted to make a plug here to please also stay tuned to the International Stroke Conference, as there may be more evidence-based stroke clinical guidelines released at that time. However, it takes time to update processes, and these changes won't happen overnight, and we wouldn't require anything to change in your processes, but it's really good just to keep a pulse on what the current acute stroke guidelines are, so you know where your program is moving into the future. So here's a snapshot of new and similar immediate actions that you might see in your final site visit report. Immediate actions are to be addressed within 6 weeks from when you receive your site visit report. You will receive information along with your site visit report on what to address and how to do so. So what could be assessed as an immediate action at site visit time is any recommendation from your previous site visit that was not addressed or begin to be addressed by the time of this site visit. So along with our communication of scheduling your site visit, I do send out that previous site visit to report to ensure you have all the tools that you need to make sure that you're prepared for your site visit. Another immediate action, and this is actually not much of a change from last time around, but a little bit more zeroed in this time, is any concern for patient safety, such as Alteplase administration best practices not being followed. This may be evidenced through the review of cases, seeing trends in those case reviews, interviews with staff, and review of protocol, and documents that don't align with guidelines, such as inclusion-exclusion criteria, order sets, etc. And a third common immediate action is if there's any unmet acute stroke ready hospital designation criteria. So a new one that we're kind of zeroing in on here is if your stroke specific memorandum of agreement for transfer is not updated according to the way we've outlined it in the acute stroke criteria, and if it does not have a current date. This is an example of what an unmet criteria might mean for an immediate action. So here is a snapshot now of, we'll go through a couple new recommendations you might see in your final site visit report. Because we're moving the site visit closer to the submission deadline that I've already talked about, you will not receive a set of recommendations to complete before the site visit. Again, we removed that step to make the process more efficient. Instead, the application review committee will result in its own additional recommendations that they viewed based on what you submitted that will be added to your final report. Some of these, I listed some of the examples that you could see in your report based on that internal review, may not be explicitly verbalized by your site reviewer at the site visit, yet they are all still part of the complete review of your stroke program's designation application. The internal review when you submit your documents, and then the review of those in real time at your site visit. So all of these are pulled together for your final designation application, your final designation report. And just the same as last time around, any recommendation that's listed is required to be addressed by the next designation cycle. So that does give you a full 3 years to implement all of these recommendations thoughtfully by the time it's time to redesignate. Another new recommendation this cycle. If a thoughtful education plan was submitted, which is part of the requirement of what you're submitting in the portal, yet validating education was challenging. For example, everything else in your education plan looked great, yet it was difficult to verify the one locum file that the reviewer chose to review to check if they had stroke education. Then the education requirement may be listed as a recommendation versus an immediate action. But I do want to be clear here that, bottom line, the criteria requires 2 hours or 2 episodes annually of stroke education to be received by all acute stroke team members. These are all the nurses and providers, including the locums, that respond to stroke codes in the ED. This will be checked at your site visit. It may also be recommended, for example, to include a variety of educational offerings with rotating clinical topics. So you may have submitted a sound education plan, yet we don't only want to see meetings and other types of committees listed as educational opportunity. If those meetings include clinical education, such as safe alteplase administration, a mock stroke code, or NIHSS certification training, then certainly include that stroke education with those details and ensure a tracking mechanism is in place by site visit time. So what we're getting at here is that we want to see an annual rotation of these key clinical topics that are going to keep your acute stroke team members up to par to be able to activate that stroke code and according to your process and best practices. Another new recommendation this time around is establishing a standard for review, at least annually, of all stroke-related documents. Include the date of review on all of those documents for consistency. Included in the review is looking at your protocol, your corresponding cheat sheets, your algorithm, your order sets, etc. This assists in maintaining a level of awareness and engagement for all that respond to stroke, all those involved in your stroke program, and ensuring that your processes meet the best practice of changing stroke guidelines. Therefore, as you update your stroke protocols and take a look at all of these items annually, ensure that you have consistency in language, and standards goal times across all documents, and include the most current guidelines from the American Heart Association, American Stroke Association guidelines for the early management of acute stroke. It is suggested to work with your primary stroke center or comprehensive stroke center or telestroke partner as you do a review of those documents. And this might typically occur within your stroke committee. And again, it's looking, you'll see this recommendation, we're looking for that review annually. And proof of that would be showcasing that on the timestamp of all those documents. So we really hope this helps answer your burning questions and kickstarts you on your way to redesignation. So here are a few final reminders and takeaways for you today. Please be aware of your own acute stroke ready hospital designation deadline. Check out your certificates and your previous communications with us and submit your documents on time, if not earlier, actually, if you're able and able to do so, in order to kickstart the site visit process. Please do your homework and prepare in advance for both the submission time and site visit time. The resources page on the Minnesota Stroke Program website has all of the information that you need for designation and also for site visit. Please also take a look at the Minnesota Stroke Portal now to view and certainly feel free to start your online submission of documents. And if you have any issues logging on, you have changes in contact, that's the time to kind of check all that out and get in touch with us so you're really set for that deadline to submit on time. Please also remember to stay tuned to friendly emails from us at MDH, these are largely occurring from Nikki and I, and Al sends out monthly stroke program information. These will occur especially from Nikki and I prior to your deadline to ensure that you're all squared away and set to submit, and we're here to help. So this is an open door process during that time. And please also continue to update MDH with any stroke program contact updates. We really appreciate you keeping all of those contacts up to date with us. It's a lot to track, and we appreciate your communication in advance about that. You can send those updates to us personally at MDH or to health.stroke@state.mn.us. And as always, thank you for your continued partnership and participation in the stroke system. As an acute stroke ready, we're really making a lot of awesome progress together. So thank you kindly. And Nikki, I think I am turning it back to you.
All right. Thanks, Michelle. Thanks for going over all those frequently asked questions that we've had coming in over the last few months. I did just put the survey link into the chat box here. So that's the link that we hope you will fill out the survey to provide some feedback and give us ideas for future webinar topics. At this time, though, it looks like we do still have some time for questions. So for those of you that are unfamiliar with WebEx, you can click on *6 to unmute your line, or you can unmute your microphone too if you're connected to your computer. And the third option is, as always, to type in the chat. Michelle, I don't see any questions in our chat and on my side. Do you happen to see anything on yours?
Just one question here on some logistics. Just a reminder, yep, this webinar and all of our monthly webinars are recorded and takes within the next 1 or 2 weeks, and it will be live on our YouTube page. That information and link to our YouTube page will go out with the follow-up email that Nikki will send. So it can be reviewed again for yourself and for any of your team members that might have missed it that you want to share. And that is, that's all I'm seeing, Nikki, but we are here for another 5 minutes if anybody would like to ask any questions about designation and site visits or anything else. Okay. Well, Nikki, I think we've given a little bit of time here. Thank you, everybody, for tuning in. We will send this information out in a follow-up email, and it looks like we will close up.
Yeah, thanks, everybody. Make sure to stay tuned for an invite for next month, and stay well and take care of yourselves and each other. Bye, everyone.
Bye, everyone. Thank you.